Welcome to AETCM, the Emergency Medicine channel. So, shall we start?
Yeah.
37-year-old male patient came to our ER with complaints of fever associated with chills and rigor, and is also complained of general tiredness and cough with expectoration since 1 week. On arrival, initial 10-second assessment and primary survey, patient was conscious and oriented. On airway, it was patent. There is no any pooling of secretions. Breathing part, air entry bilaterally equal with respiratory rate is 44 breaths per minute and saturation is 95% on room air. Coming to circulation, BP was 140/90 with pulse rate is 126 per minute and CRT less than 2 seconds. Coming to disability, GCS is E4, V5, M6 and pupils bilaterally equally reacted to light. And exposure temperature was 99 degree Fahrenheit. This is the initial primary 10 seconds survey.
So the patient is tachypneic
And
also tachycardia is present.
Tachycardia is present with temperature 99.
99.
GCS was full.
Okay.
So coming to the adjuvant to primary survey, we have taken a VBG. VBG showing pH 6.8, PCO2 15, PO2 90, bicarbonate is 2.8. So there is in VBG wise there is compensatory metabolic acidosis is there. So we done a GRBS was done. So it's showing 790 is the blood sugar. With other VBG findings is anion gap is 23, potassium is 6, sodium is 129, corrected sodium is 140, with creatinine 1.16.
Okay. All right.
So patient with symptoms of tachypnea with VBG showing metabolic acidosis, which is high anion metabolic acidosis, with the criteria fulfilling the criteria of the diabetic keto acidosis. 1 DD we can take.
Okay. That's the DD that you've got as well. All right. So let's go there directly. When we talk about, I suppose the case is about diabetic ketoacidosis right now. As we all know, we have multiple videos on diabetic ketoacidosis. But one thing that we all should remember is that diabetic ketoacidosis is something that an ER physician should be going through over and over again, because this is one of the most dreadful acute complication of diabetes. It can be sometimes the initial presentation of a type 1 diabetes mellitus patients, mostly pediatric age group. Can also be at times the first presentation, rarely in adult patients with type 2 diabetes mellitus also. This particular diagnosis should not be missed. It is easy to catch and very responsive to the treatment. But in case we miss the diagnosis, the pathway is going to be very hard for the patient and for you as well. So to go over it again and again is good, according to me. Diabetes mellitus, the acute, as I told you, is a diabetic ketoacidosis, an acute complication, right? Now, when this patient is presenting to you, so as an ER physician, what you see is most of the time the patient is being rolled into the ER on a stretcher or a bed, and the first thing you see in a patient, what all are you going to look for, which would suggest that the patient will have, might have diabetic ketoacidosis?
Clinically, we can check for common like tachypneic. Patient who comes tachypneic, we can rule out like if there is bicarbonate loss is there, acidosis is there, there is not compensatory, there is respiratory component is there. So,
yeah, correct. So there is going to be respiratory alkalosis. So clinically, you'll see it as the patient is tachypneic or hyperventilating.
Then sometimes we get Kussmaul's breathing.
What is Kussmaul's breathing?
Ketone body smell, the fruity smell.
Okay, increase in rate and depth of breathing. Yes, and you get fruity breath also. If you're an overzealous clinician, you can go near the patient and smell the fruity odor, provided that you're ready to bear the complications later. And what else is there?
Clinical features are like patient has abdominal pain, nausea, vomiting, altered sensorium, sometimes seizures, sometimes an illness like fever, infections.
All right. So we can break down the subset into the features of diabetic ketoacidosis, and one of the other features being the stressor part, which would lead to diabetic ketoacidosis. So as you said, tachypnea, tachycardia is going to be there in the patient. The mucous membranes are going to be very dry,
Dry.
because the patient is losing a lot of fluid or is dehydrated. The patient can be in tachycardia as well, compensatory to maintain the cardiac output, right? And also at the same time, the patient will have abdominal pain, nausea, vomiting, and all that. And we can also, at this point of time, okay, this is how you saw the patient and realize that, okay, this might be the condition, right? When you go to the history part of it, what are you going to stress on? What all are you going to ask?
Basically, it is a relative insulin deficiency. So the type 1 diabetic patient or type 2 diabetic patient, we can ask the history, like there is history of any skipped medication of insulin.
Skipped medication. That's one of the most common cause, right? Very good.
Then any infection cause, like to rule out inducing the DKA.
Right. So that would bring us to the next question. What are the common etiologies for
Common etiology like infection, sepsis,
what are the most common infections?
LRTA, UTA,
LRTA, pneumonia, UTI.
pancreatitis.
Okay, yeah, pancreatitis, inflammatory, yes.
Inflammatory infections, then MI, stroke.
MI, stroke. Basically, any stressor can lead to diabetic ketoacidosis. So everything can be pinpointed. Pregnancy is there, myocardial infarction, stroke, everything. Any iatrogenic causes for diabetic ketoacidosis, like medications I'm talking about. So what are the medications that can push into diabetic ketoacidosis in the patient?
Steroids.
Yes, very good. Steroids, yes. Any sympathomimetic drugs can cause, yes. Atypical antipsychotics can cause, yes. Olanzapine, clozapine, risperidone, these are some of the agents. What is one group of anti-diabetic medications?
Euglycemic diabetic ketoacidosis by the sodium glucose transporters.
Yes, SGLT2 or your gliflozins, right? What happens there?
Basically, it causes glucose excreted by the urine.
Right. So they enhance the urine, the glucose excretion via urine. Proximal tubule, there is no reabsorption. 90% of glucose reabsorption happens there. So it's going off. What happens in the serum? Then glucose levels are low, because of which insulin levels will be relatively low. And because of this, your relative counter-regulatory hormones come into play, and that vicious pathway is set up on. Understood? Now, we finished the etiology aspect of it. One more thing is substance abuse, like as in cocaine users, because again, that is sympathomimetic in action. That can also lead to this. Yeah. Let's move on to the pathophysiology. So in our body, we all know that our body is in homeostasis, right? So there is always balance of hormones with the counter-regulatory hormones, or there is some feedback mechanism, negative feedback mechanism, which ensures that everything is happening in a systematic way. So for example, you have your calcitonin parathormone, you have your RAS pathway, atrial natriuretic peptide, and brain natriuretic peptide. Similarly, insulin has its counter-regulatory hormones. Mainly, which one is the counter-regulatory hormone? Glucagon. Along with it, you have catecholamines, growth hormone, and also cortisol, right? What happens? There is a relative insulin deficiency, as you rightly said, or complete deficiency. What happens? There is glucose excess in the blood right now. So our body wants energy to work, right? But the glucose is in excess in the body. So because of this excess glucose, the initial physiological mechanism to adapt to this is by drinking excess water. The patient starts drinking water. But now this is not enough to compensate the increase in plasma osmolarity. Eventually because there is no more hepatic gluconeogenesis as well, because the body thinks that there is no enough glucose in the body. That is why it keeps starting to produce more and more glucose. Glucose is in excess.
Exactly. Insulin deficiency, cell is not able to uptake the glucose.
Exactly. Very, very correct. And then after that, what happens? The renal threshold is achieved, and then you have glycosuria. Glycosuria, what happens? It is an osmotic diuresis is happening. Along with what all is being lost, a lot of things are lost. A lot of electrolytes, sodium, potassium, chloride, calcium, magnesium, phosphate, everything. You name it, everything is being lost in the urine. Now, in this case, what happens? Dehydration is happening, and pre-renal azotemia can happen, and eventually the patient is becoming dehydrated. There is a component, the most important component is the intracellular dehydration which is happening. So that is something that you should keep in mind. Now, that is one part of it. Now, because the body needs energy ultimately to process. What happens? The counter regulatory hormone starts utilizing what else?
Initially, it causes gluconeogenesis. Then it causes, due to insulin deficiency, causes lipolysis, like other substrate like fatty acids to form energy. So, and product form ketone bodies.
Ketone, fatty acid goes to your
lysis.
exactly. Hepatocytes and the beta oxidation happens. Your fatty acids are being released. Now the fatty acids again will cause high anion gap metabolic acidosis, compensatory respiratory alkalosis. You're hyperventilating. There's a lot of moisture in this. Again, dehydration will happen. Ketonuria will happen again. Again, because of the ketosis, what is there? You again vomiting might happen. So you vomit again, dehydration happens. So this is a vicious cycle. Your duty as a physician is to identify that this vicious cycle is happening and to pull this, stop the vicious cycle and pull the patient out. Right. So the pathophysiology has been addressed right now. Now I want you to talk about what else can the differential diagnosis be in case of DKA.
Diabetic ketoacidosis is a high anion gap metabolic acidosis. So other causes of high anion gap metabolic acidosis like lactic acidosis, acid ingestion, ethanol ingestion, methanol ingestion, paracetamol poisoning, then aspirin, starvation ketoacidosis, alcoholic ketoacidosis, sepsis.
Dehydration also can cause, right? So yes, what is the difference between HHS and diabetic ketoacidosis?
Difference is, one is serum osmolality. Serum osmolality is more in calculated serum osmolality is more in HHS, and ketone body is negative in HHS.
Negative or small.
The loss of water is more than DKA.
Yes, right. Okay. Now let's move on to the laboratory investigations that we normally do. Before that, let's address how can you term the patient as diabetic ketoacidosis? What are the lab values that you would normally say?
Diagnostic criteria. Blood sugar is more than 250 with serum ketone positive, with bicarbonate less than 15 and anion gap more than 10 to 12 milliequivalent.
10 to 12 milliequivalents. So that's the right. How do you term it?
7.3.
pH less than 7.3. Mild, moderate, severe. How do you?
Mild is less than 7.35. Mild is 7.25 to
7.2 to 7.3.
And moderate
corresponding
is
bicarb would be how much?
More than 15 to 18 is the bicarbonate.
In mild.
Moderate is 7 to 7.24 is the moderate. With 10 to 15 milliequivalent is the bicarbonate. In severe is less than 7 and bicarbonate less than 10 milliequivalent.
Less than 10 milliequivalents. All right. Okay. Now, if the patient is so we also know that the patient can present with abdominal pain. And at times the patient can present with some neurological abnormality as well, which is pushing the patient to DKA. If the patient is having severe abdominal pain and is presenting to the ER, how can you know that it is an acute abdomen or it is a pain due to DKA?
How to differentiate?
Like as in, if you don't have any lab parameters with you right now, how are you going to differentiate? So one thing that we generally see is that the first 4 hours of your DKA resuscitation is of utmost importance. This is where most of the transcellular shifts are happening and a lot of correction is happening. So if at all within the 4 hours with your proper resuscitation, if the patient feels better, you should do serial examination every hourly or so. If the patient's abdominal pain is improving, you can put that on DKA. All right, and of course you have your lab parameters as well. But again, amylase, lipase and all will be elevated in DKA as well. Secondly, if it is a neurological thing. Plasma osmolality is a very important. Any plasma osmolality more than 320, the patient can be in stuporous state or in comatose condition. Okay. So we've discussed this thing as well. Now let's talk about the laboratory values of it. The ketosis part is what I'm stressing upon.
Ketone body came to be 2+, and counts are raised. Total count is 20,000 CRP is 190. Hematocrit is initially hematocrit is 50 and HB was 14. Creatinine was initially 1.16. Then potassium 6 and sodium 129 is the VBG sodium, corrected sodium according to the sugar is 140.
Okay. Okay. How do you correct the sodium correction? How is it done?
Every 100 milliequivalent we can correct by 1.4 milliequivalent, and above 400 we can correct by 2.6 milliequivalent.
2.6. Right. For every 100 milligrams per deciliter
100,
rice in 100, 1.4 correction is
more
happening.
than 400, 2.6.
Okay. All right.
Otherwise, we can use calculator.
Calculator. Yeah, that would be easy. Yes. Right. Now, when we talk about ketosis, one thing that I want to add is it's a equilibrium. Again, it's a to and fro reaction. Acetoacetate plus NADPH gives rise to beta hydroxybutyrate plus NAD. So why I'm stressing upon this is because in a case of lactic acidosis, what happens is NADPH levels would be on the higher side. So acetoacetate plus NADPH, the reaction would shift to the right, giving rise to a lot of beta hydroxybutyrate and NAD. All right. Now, the nitroprusside test is the normal test which is used in urine dipstick. That would only detect acetoacetate. So when you do initial test, it might come as low because the reaction is shifted to the right and a lot of beta hydroxybutyrate is being produced right now. That is one fallacy of this. Secondly, when you start treating and the lactic acidosis improves, what happens? The reaction shifts to the left again. So acetoacetate increase. So when you're trying to monitor by urine dipstick, the patient might look worsening. Understood. So that is something that I wanted to stress. Next comes your potassium, hypokalemia, hyperkalemia. Normally what happens? Why is hypokalemia present in DKA?
Every pH increased by 1.5, there is potassium exchange will be there.
Okay.
Of 0.1 milliequivalent potassium.
Right.
So
we just think this way. One of the treatment that we give for hyperkalemia is giving bicarb. That means you want to induce metabolic alkalosis, which promotes intracellular shift. And there is metabolic acidosis. What happens? There is extracellular shift. So the total potassium in the body might be actually low. The serum concentration might look elevated, but there might be an actual deficiency of the potassium in the body. That is something that we should keep in mind. Now, in this patient, how much was the potassium?
6.66.
6.6. All right. So, how did you proceed with the management of this patient?
In this patient, initially we started with hydration.
IV hydration.
IV
First and
hydration,
foremost.
20 to 30 ml per kg per hour. Initially, we can start for the first 1 to 4 hours. So we can give it is by 2 liter to 2 hours, 2 liter to 2 to 6 hours, 2 liter to 6 to 12 hours.
6 to 12 hours. But you guys are very good in using focus and everything. So you do USG guided resuscitation. Yes.
So in this patient, hematocrit is 50. Patient is initially dehydrated. We started on fluids. Then initially started on 2 liter fluids. Then patient sugars is 790 and potassium is 6. So we can directly start on insulin infusion in this patient. We can start with 0.1 international unit per kg per hour infusion.
0.1 to 0.14 you can start. What if the sugar levels were less than say 3.3, say 3.3? Less than 3.3. Sorry, the potassium levels less than 3.3.
Less than 3.3, we initially start with potassium infusion. Correct the potassium or the 3.5, then we start on insulin infusion.
Okay, all right. What if it was between 3.3 to 5.2?
We can start both insulin infusion and potassium.
Potassium. Okay. Potassium correction, how would you do then?
We can peripherally correct by 20 milliequivalent to 40 milliequivalent. We can correct. If there is underline is there, we can correct up to 60 milliequivalent. We can correct.
Okay. So generally 30 to 40 milliequivalents per liter at least you should be correcting. Right. After that, proceed. You started fluids for the patient. Fluids is also of utmost importance because for the insulin to act, there should be some reservoir. As in the subcutaneous. I'm talking about the IV right now. IV is fine. But in general, if you're planning to give subcutaneous, perfusion should be there. Yeah. So IV fluids of utmost importance. You started the patient on insulin infusion after checking the potassium levels. How would you proceed now?
Then we done a focus echo. IVC was collapsing, but the cardiac dysfunction is there. So because of acidosis, 6.8 is the pH. Bicarbonate is 2.8.
All right. So there is severe metabolic acidosis which is causing a cardiac dysfunction is what you're thinking right now. Okay.
So we started on bicarbonate infusion for this patient, ideal patient for bicarbonate infusion.
All right. Now this is a very important problem what we normally face. The usage of bicarbonate in DKA, very controversial topic. Right. pH less than 6.9 with
6.9
cardiac dysfunction is definitely an indication for bicarbonate infusion. You can go ahead and start bicarbonate infusion. And also one thing that we should continuously check is because the bicarb is eventually, is reflected as PCO2, the patient should be able to ventilate it out as well. You should keep a check on that. And there's a lot of sodium load being given when bicarbonate infusion is started. So effective dilution should also be used, right?
Then we started on IV antibiotics because patient presented with fever, cough, LRT symptoms, total counts and CRP is raised. So we started on IV antibiotics. Then we done a USG test was done showing bilateral LRTA features like B lines and like focal B lines with consolidated features.
Okay.
So before X-ray, we initially diagnosed patient had LRTA, that infection causing the stress, causing the DKA is our initial diagnosis.
Right. So you were addressing the pathology which pushed the patient to diabetic ketoacidosis, right? So
This is the
all right. So
coming to the secondary sample history. 37-year-old male patient with there is known case of newly diagnosed diabetic, not on any medication, and there is no history of allergy. Patient presented to ER with complaints of fever with chills and rigors associated with general tiredness and reduced appetite. Patient also complained of cough with expectoration since 1 week. Then patient followed by complaints of dyspnea, which was progressively worsening since 2 days. There is no history of chest pain, orthopnea or PND. Orthopnea and PND. And patient also complained of nausea and abdominal discomfort.
All right. So the abdominal pain that we normally talk about, what is the root cause for the abdominal pain?
Ketone
body and also prostaglandin I and E2. These are both responsible for that. Especially in pediatric DKA, this might be the only presenting feature, abdominal pain. Just wanted to add that as well. So in this patient, how did you manage after this? What happened?
Then first of all, we start on fluids, and according to Delta protocol, we will set the insulin infusion titrate. If there is any, when monitoring the ketone body, 12th hourly we are monitoring, and potassium we are monitoring 8th hourly, repeating the potassium. Then we take an X-ray showing bilateral pneumonia features. Later on, patient desaturated. So we put on patient on, then that time ABG showing type 1 respiratory failure.
Okay.
So we put on patient on HFNC. Now patient is coming to normal. His counts and CRP is decreasing.
Great. So how would you determine whether the endpoint of the DK resuscitation has
this is crossing of anion gap with ketone body becomes negative. Both things we will check.
Okay, pH more than 7.3. The bicarb should be more than 15. Anion gap is closing. Ketone body is negative. So how do you transition from the IV to the subcutaneous? When do you decide? How do you transition from stopping the IV? How do you do that?
Normally, we will, after it gets negative and it is normal, we will take 24-hour the insulin usage of IV. Then in our hospital, we will take immunotherapy. There is no to follow this thing. There is no that guideline. In that we will take an injection immunotherapy, and the requirement dose will take 24 hours requirement dose. We can take the 2/3 and divide the 2/3 into 3 parts. That we can give half an hour before the meal of TAD. Then the 1/3 we can give 2 hours before the insulin infusion to stop subcutaneously. We can give insulin infusion by that 1/3.
All right, that overlap is very important because if at all we don't provide that, in the next 1 or 2 hours, the patient will tip into DKA again. All right. We talked about euglycemic diabetic ketoacidosis. Who are the most, just to keep in mind, who are the normal patient population who would present to us with euglycemic diabetic ketoacidosis?
Older group patients.
Older age group patients. Okay.
Patients are taking on this sodium glucose transporter.
SGLT2. Correct. Very good. Anyone else? Pregnant patients, yes. Pediatric patients with DKA with presenting with a lot of vomiting, yes. Who have a low reserve of hepatic stores, like as in liver disease, and all that, alcoholics especially, who's in starvation. These are the main population that you should keep in mind who can present. And also one important patient population is if they've gone to an outside hospital and they saw that okay the sugars are very high, they would have given an initial IV or a subcute dose and send the patient here. That patient might have a reduced sugar level, but that doesn't mean that the patient is not in ketosis. That is also very important. All right. Right. What are the complications of DKA?
Complication of DKA, one is like fluid treatment causes hyperchlorometabolic acidosis.
Very important.
Okay.
Something that we didn't address. Hyperchloremic metabolic acidosis can contribute as a normal anion gap metabolic acidosis. So when the DKA is being treated, one of the reasons why the anion gap doesn't or the acidosis doesn't resolve is because of this as well. So that is why judicious administration of fluids is important and the choice of fluid is important. That is why, again, a controversial part. Some people prefer NS, but RL can also be used. RL or plasmalite, exactly, very good. Can be used for the resuscitation, which can prevent this part of right. And what else is there?
Other thing is fluid overload causes acute respiratory distress.
Yes, fluid overload. But that doesn't happen here because we do fluids resuscitation with guided focus. Right. Next.
Then next is normally mostly commonly caused in infants like cerebral edema.
Right.
Acute management and acute lowering of the blood sugar and osmolality causes cerebral edema.
Right.
Other than that.
Right, complication of DKA it is a hypercoagulable state.
Hyperglycemia, electrolyte imbalance, hypokalemia.
Hypokalemia is one problem where significant cardiac dysarrhythmia and all can happen, which should be treated immediately. And hypercoagulable state can cause stroke, myocardial infarction and all that, venous stroke and all that. Next, what about DKA in pregnancy? What is the issue with the DKA in pregnancy? Any issue with the pregnant, whatever the pregnant mother is having, it can be hyperglycemia, acidotic state, any of this will be reflected in the fetal circulation as well. Acidosis will cause decreased fetal blood flow through the placenta. Fetal hyperglycemia will be there, and this will cause acute changes in the fetus circulation as well. So that is something. So pregnant DKA patients should also be managed or caught early is what I'm trying to say. Anything else that you want to add in the DKA discussion? All right. We'll wind up.
Thank you, sir.
Thank you.